I'm the director of the Urban Health Institute at Charles R. Drew University of Medicine and Science. I am pleased to welcome you to the Dr. Erik Fleming annual lecture. We have a terrific agenda in store for you today. Next slide. But before we go into our agenda, I wanted to introduce our president and CEO of Charles R. Drew University of Medicine and Science, who will be providing a welcome to you all. Please join me in welcoming Dr. David Carlisle.
Well, greetings everyone, and good afternoon. As now, let's see, 12:02. It's wonderful to have everyone assembled here. I see that we have well over 45 participants and growing. This is the first Dr. Erik Fleming Memorial Lecture. And it's indeed an honor to memorialize Erik's name here at our university because he was such a central part of our university. And I note that his parents are with us as well. I want to recognize Dee and Art as well for their contributions, including, of course, fundamentally bringing Erik to us. So thank you very much. I want to be brief and note that in addition to celebrating, I think the heroic battle that Erik engaged in, maintaining his tenacity and perseverance here at our university, through to the point that was no longer possible, and inspiring so many of us at the university who are facing other challenges and similar challenges to do the same. Erik is forever memorialized in the spirit of Charles R. Drew University, because when you think of our vision statement, the last phrase in our vision statement came from Erik Fleming. I remember we were in a large meeting, scores of people trying to figure out how to parse the words of our vision statement succinctly, effectively. And I remember Erik raised his hand and said, how about in a world without health disparities? And hence the vision of Charles R. Drew University has been for the last, I think, 7 years, excellent health and wellness in a world without health disparities. It's that last phrase, a world without health disparities, that Erik has forever contributed to Charles R. Drew University of Medicine and Science, because it succinctly captures what our university is about. I want to offer a challenge to everyone here at CDU. And this is what I'll call the Erik Fleming Challenge. Every day before you go to bed, think about what you have done that day to achieve the vision of a world without health disparities. And remember the name Dr. Erik Fleming when you do that. Thank you very much, and I'll turn things back over to Dr. Partlow.
Thank you very much, Dr. Carlisle. Next, I would like to introduce our Vice President of Research and Health Affairs at Charles R. Drew University of Medicine and Science, Dr. Jay Vadgama, who will provide greetings as well.
Thank you, Dr. Partlow, and thank you, Dr. Carlisle. Welcome. Please know that I'm extremely honored, actually humbled, to know that the family, the Fleming family, Dr. Arthur Fleming, Professor D. Fleming, Mrs. Starr Fleming, and of course, Erik Jr., thought of me to say a few words of welcome. Thank you, and please know that I'll always be grateful. I also want to thank President Carlisle, Dr. Kyosho Partlow, and our entire UHI team for organizing this special lectureship honoring Dr. Erik Fleming. Please know that all of us at CDU and the entire Fleming family and friends are very, very grateful. Thank you. And thank you for those beautiful words of introduction, Dr. Carlisle. Dear Fleming family, Dr. Robin Mendelson, our keynote speaker, friends and colleagues, I welcome you to celebrate this special day. It's truly a celebration to honor our good friend and colleague, Dr. Fleming. I welcome our colleagues from RTERN. Many of you remember RTERN is the RCMI Translation Research Network, which is really a key focus of a lot of our RCMI institutions. Many of the leadership from the RTERN are on call. Dr. Fleming, Erik Fleming, actually started his earlier career working with the RTERN organization. I know that my colleague, Dr. Bazargan, is going to expand on that later on. I know that many of Erik's friends have joined this very special and auspicious occasion, so thank you. I think from what I had heard, we may have over 100 participants who will be registering today or have already registered, so thank you. This is just a small reflection of their love and appreciation of Erik and the Fleming family. As based on the agenda, we'll have presentations from our keynote speaker, Dr. Mendelsohn, our friends and colleagues, especially Drs. Bazargan, Dr. Partlow, and Dr. Vargas, who will share some more closer kind of reflection of on Dr. Erik Fleming. Before I hand over to the next presenter, I'd like to share some really impressive personal information that I apologize I was able to get from Erik's dad, Dr. Arthur Fleming. I would love to share some of that with you. And what are the special qualities of Erik that many of us, perhaps at CDU, we look at him as our colleague, our research colleague, our faculty colleague, but there was something a lot more about his personal life and his upbringing. So how would I classify or categorize Erik as a human being? One of honesty, integrity, unselfishness, compassion, loving, and a humanitarian. Erik was recognized as a South Bay hero. And this is a beautiful story that Art shared with me. At the age of 10, Erik was acknowledged by the Daily Breeze, a very well-known prominent newspaper in the Torrance South Bay area. And the article was entitled for his birthday, The Giving of Gift. For the last several years, Erik, this is around the age of 10, had invited his friends for his birthday party. As many 10-year-olds, when they had the birthday parties, they think of gifts and partying and fun. Well, Erik's invitation requested that the donations for his birthday be made to the homeless in lieu of his presence. Help the homeless help themselves is a foundation of which his mother was a member of. Just an incredible thinking and outlook, just at a simple young age of 10. Erik was always an achiever, determined to succeed, whether it was academic, sports, a writer, or a poet. I know he was pretty fierce about his sports, particularly his rugby days, from what I remember. He had extraordinary achievements in his academic grades. I think he got a straight A in his almost all 8 years in his elementary school, high school, at the Rolling Hills Country Day School. Just incredible. One thing which really struck to me and touched my heart, and I'm going to read this little piece. If I go over a few minutes, I apologize, Dr. Partlow. In 1993, Erik wrote about what it means to be an achiever. He was selected as an achiever by a civic organization. And this little piece of writing that Erik wrote many years ago really touched my heart. And let me read this to you, if I may. What it means to be an achiever. And Erik writes, as I anxiously await the start of my journey through life, ready to set out alone in the great big world, I know that I am well prepared. I am also aware, however, that my journey will not truly be successful unless I eventually come full circle. Being an achiever is not being satisfied reaching one's own goals, but rather reaching out and helping others to achieve their dreams. At the very least, I know that I must lead by example. As an African American male, I will always observe as I chart my course through life. My successes will probably be overlooked. My failures, however, will certainly reflect the Black community as a whole. Being an achiever is about refusing to fail and transcending the stereotypes that are so prevalent in society. Furthermore, I will not allow my identity as a successful Black man to be dismissed as a rare exception, because being an achiever is about networking to support one's peers. Being an achiever is a great honor and a privilege that has put me at a great advantage as I prepare to take my place as a leader in the world of tomorrow. My friend Erik, our friend Erik, Dr. Erik Fleming, you are truly a leader and will always be. And we are very grateful that you have touched our hearts. Thank you very much. And I will give it back to Dr. Partlow.
Thank you very much, Dr. Vadgama, for the greetings and for sharing. Hopefully you've had an opportunity, all of you, to take a look at the great agenda that we have in store for you all today. Next slide. Really quickly, I just wanted to go over the objective of the Dr. Erik Fleming annual lecture. It is to honor Dr. Erik Fleming's legacy through an annual lecture that promotes awareness and engages discussion around health disparities, place-based research, and health policy for the advancement of underserved and under-resourced communities. Next slide. I would now like this opportunity to introduce our professor and faculty trustee of Charles R. Drew University of Medicine and Science, Dr. Mohsen Bazargan, who will discuss Dr. Erik Fleming's research and also share as well memories. Dr. Bazargan?
Those we love do not go away. They walk beside us every day, unseen, unheard, but always near. Still loved, still missed, and very dear. Dr. Erik Fleming was an unbelievably dedicated, hardworking, talented, and kind person. Personally, I learned a lot from Erik. When he was in tremendous pain and while he was taking numerous chemotherapy treatments, he never complained. He just kept coming to work, sometimes directly from hospital. Well, let me be honest with you. I only heard one time that he complained. With tearful eyes, he told me, "I'm so weak, I cannot hold my son." That was the only complaint that I heard from him. A few months before he passed away, he submitted a grant application. It happened that I was one of the reviewers. He did a great job. I was amazed. I do not know how he was able to produce such a well-written proposal when his body was so weak. I just don't know. Yes, his application was well received by other reviewers, and it was funded. Erik never gave up. He truly was a dedicated researcher to underserved community, as Dr. Vadgama mentioned, and also our president. One of his beautiful peer-reviewed paper was titled "The Role of Translational Research in addressing health disparity, a conceptual framework. The paper appeared many years ago before other researchers paid any attention to concept of community-based participatory research and translational research. This is a paper that has been recommended by Shazi to all of our medical students who conduct translational research. This paper is posted on Medical Student Research Thesis Program website. By the way, I had the pleasure to serve as one of his professors when he was earning his master's degree in early 2000. Such a beautiful memory. This is true. When a loved one become a memory, that memory become a treasure. That being said, I'm truly honored to present this event to you. First of all, I would like to thank our president sincerely for establishing Dr. Erik Fleming annual lecture to honor Erik. Thank you, Dr. Carlisle. To the best of my knowledge, this happens only once for late Dr. Haynes. Dr. Carlisle, I meant it. Thank you for doing that. So Erik was graduated from Brown University in 2002 with a bachelor degree in community health. And then later, he finished his master degree and finally his PhD in 2014, to the best of my knowledge, from Walden University. He had extensive experiences with database design as well as quantitative and qualitative data analysis. As I said, he published earlier several manuscripts that you may find in his dossier. Anyway, this is truly an honor to introduce him. My last note, I also would like to thank everybody who attending this meeting. I know the member of Board of Trustees are here. Dr. Kaushik are here. Thank you, Dr. Kaushik. And a special hello and thanks to Star Fleming, his wife that is with us. So thank you again. And I'll pass it to Dr. Fleming, Dr. Partlow. Thank you again, everybody.
Thank you very much, Dr. Bazargan. Can we advance to the next slide? Thank you. So here are highlighted publications and presentations featuring the work of Dr. Erik Fleming many of which Dr. Bazargan just mentioned. So we just wanted to share those with you, and we'd be happy to provide links to these as well following the lecture to everyone who registered today. Next slide. We also wanted to share, take opportunity to share with you some photos that really capture his work, his collaborative effort. He was indeed a true collaborator in research at CDU. He also, really worked with our students and was eager to help mentor them and provide any guidance and advice with respect to research. We have a video clip to share with you with him offering advice and guidance to our students. This was a few years ago.
To generally jump in and say, for all the, one of the more difficult parts of the research process is really just getting that idea formulated. Once you've got your idea and you know what you're going to do, the other steps kind of take care of themselves. But all of us up here, more than happy if you just need people to, sounding boards, people to listen to, help you to work through your ideas or help you figure out how to operationalize your idea, put that into action. That's what we're here for, and we're always more than happy to help.
Indeed, he was always eager to help students and colleagues alike. Next slide. And here's some additional photos, including photos with his son, little EJ, helping to assist him in his work as well. Photos with his parents as well. And again, also attending various research meetings. Next slide. We now turn to our featured presenter and guest today, Dr. Robin Mendelson. Dr. Mendelson came highly recommended by the Fleming family. Dr. Mendelson is a gastroenterology specialist, having over 17 years of experience with gastrointestinal oncology, esophageal disorders, and anal and rectal disorders. She has a particular interest in working with people who are at high risk for developing colon cancer and rectal cancer because of hereditary conditions such as Lynch syndrome, as well as those with young onset colon and rectal cancers. In recent years, she has been able to reduce colon cancer rates through preventive measures. Please join me in providing a warm welcome to Dr. Robin Mendelson.
Thank you. It is really an honor and a privilege to be invited to give this talk. I did not have the privilege of being able to work with Dr. Fleming, but he sounds like such an amazing person, and I hope that this talk lives up to his expectations as I try to be the achiever that he spoke about. So I'm going to speak about young onset colorectal cancer. And just to begin, so these are overall trends in colorectal cancer in the United States. And as you can see, since the 1990s, we've seen a nice decrease in the incidence of both colon and rectal cancer. But it's important to realize that this is not the case worldwide. And in some places, we have seen no change in the incidence. And in others, we've seen an increase in the incidence of colorectal cancer. So why have we seen this decrease in the United States? Well, it's likely multifactorial due to modification of risk factors, improvements in treatment, but the majority has really been attributed to colorectal cancer screening, most notably colonoscopy, with the identification and removal of precancerous polyps. Now, we'll go over screening guidelines in a little bit, but it's been traditionally the group that has been screened are those over 50. Now, what about those that aren't screened? So we have seen an increase in incidence in those under 50 since the 1990s, and it's actually increased about 1 to 2% per year for a total of over 60%. And as you can see from the mortality curve, the mortality had started to drop. And then since the 1990s, we've seen a plateau and now an increase. This is not unique to the United States. This is actually a global phenomenon. If you look at this graph, the red are statistically significant increases in incidence, and the gray is stable or insufficient data, and blue are decreases. So as you can see, in the majority of the world, it's either been stable or increasing. And this is being published on throughout the world, in Asia, Europe, Australia, Canada, and really in 5 continents, in Australia, Brazil, Canada, China, Japan, the United Kingdom, and the United States. But it's actually not a new concept. And when you look back, it's been published in the literature since at least the late 1990s, mostly in the surgical literature. And it really took a tragedy, I think. It took the untimely death of Chadwick Boseman this past fall to really bring young onset colorectal cancer to the forefront. When it was brought to the mainstream media, now there is a lot of interest in finding out what the cause of it and how we can prevent it. So when we look at the data, when we look at the cohort trends, what we see is that it has been increasing in all of the age cohorts under 50. but the biggest increase has actually been in the youngest age group, in the 20 to 29 group. And when we look at age-specific trends here, what we see is that these are all people that have been in the screening group. And when you look at the group 50 to 54 and 55 to 59, what you see is that the 55 to 59 group has been decreasing, whereas the 50 to 54 group, which are in our screening guidelines, is starting to creep up. And this shows it a little bit more closely that for colon, and even more so for rectum, we've seen the decrease in the 55 to 59 group, but this increase in the 50 to 54 group. And we think that the time that it takes for a precancerous polyp to turn into cancer takes about 10 years. So the question is something happening earlier that's triggering this young onset, that's triggering cancer to be found in this younger group that's still in our screening guidelines? And it looks like something changed in those that were born in the 1960s or who are 60 years old now. And that's where we really saw the start to increase in this incidence. And so the real question, and we'll go over this in a little bit, is what happened then that might have caused this? And unfortunately, predictive models show that this incidence will just continue to increase. So this is for colon and this is for rectum. Above the black line is under 50, below the black line is over 50. And what you could see is that for colon and even more so for rectum, it's predicted that these numbers are just going to continue to increase. And again, the biggest increase, this blue line, is a 20 to 34-year-old. So the biggest increase is actually in the youngest group. And based on this, by 2030, which now is not that far away, the incidence of colorectal cancer in young adults will nearly double. That 10.9% of colon and 22.9% of rectal cancers are going to be younger than 50. In other words, when we're seeing patients, 1 in 10 colon and nearly 1 in 4 rectal cancers are going to be diagnosed in those younger than 50. When we look at these cancers, so for those of you who are not familiar with the colon, we gastroenterologists are pretty simple, and we divide the colon into the right side, into the left side, and then the rectum, which is the last part of the colon before the anus. And as you can see, the majority of these cancers are actually on the left side of the colon. And when you compare that to average onset, where you see that it's spread out more throughout the colon, you see that there's clearly a difference. Now, because these under 50 are not screened, they usually present with symptoms, and the most common symptom that we found is rectal bleeding, so blood in the stool, as well as abdominal pain, bloating, change in bowel habits. And so it's really important that if you're under 50 and that you have these symptoms, to really discuss it with a provider. Because these patients are not being screened, they present at later stages. And they present at later stages compared to those over 50. And again, these are the survival rates of those under 50. And again, as you could see, it started to plateau and now is increasing. But I think when you see it in comparison to the 65 and over group, to our screen group, you see quite the contrast. On a more positive note, when we looked at our data at Memorial Sloan Kettering Cancer Center, we found that there actually was not a difference in survival in those 50 and over, which we call average onset, versus those under 50, which is early onset or young onset. And why this discrepancy? Well, we're trying to look into that now. The national data doesn't have information on treatment. So perhaps since all of our patients were treated, that is a difference, but something that we are looking into, but at least provides some information that perhaps survival may be better than initially thought. So the $1 million question really is, why is this happening? So when you think of a young person with colon or rectal cancer, you think this has to be family history, it has to be genetics. But when we look at these patients, the majority of these patients do not have a family history. So only about a quarter of patients will have a family history. And when we look back at our patients with colon cancer at Memorial Sloan Kettering under 50, we found that less than 10% had a first-degree relative with colorectal cancer. So this is a group that does not have a family history and does not seem to have a genetic predisposition for colorectal cancer. And when we looked back at our group, we looked at a little over 4,000 patients with young onset and compared them to our average onset group. And what we found was that when we look at genetic mutations in the blood, what we found was that the youngest group, so those under 35, had about a 23% rate of having a genetic mutation responsible for their colon cancer. Those in their 30s and 40s was 16%. So it was about the same as those 14%. So the majority of people will not have a genetic predisposition. And this is a busy slide. But what it shows is that when we look to see what genetic marker it was, the majority had Lynch syndrome, which is the most common cause of hereditary colorectal cancer and accounts for about 4% of all colon cancer. So this was not a surprise to us that the majority will have Lynch syndrome if they do have a genetic predisposition. Even though the majority of patients will not have a genetic mutation, I think it's important to consider genetic testing for all. Why is that? So based on our data and other data, about 10 to 20% of those under 50 will have a genetic mutation. So the majority will not, but about 10 to 20% will. And about a third of patients with mutations do not meet criteria for genetic testing. In other words, when you met these patients, there was nothing in their tumor biology or their family history that should trigger a genetic consult. It was merely the fact that they were under the age of 50. And so based on that, the majority of young onset, again, will not have a genetic mutation, but we can't predict who will have a genetic mutation, which is why we consider genetic testing in all young patients. So if it's not a family history, it's not genetics, is there something in their tumors? So we looked at their tumors and we presented this a few years ago. And when we compared our young onset again to the average onset, when we looked at mutations, they looked similar. And when we looked at specific mutations, there was some hint that perhaps one genetic mutation in the P50, one mutation in P53 was enriched in the young onset, but in further statistical analysis, it was not statistically significant. This is something that we're looking into. But overall, when you look at the tumors, they look to be the same as those over 50. So it doesn't seem to be in the tumor itself. It doesn't seem to be genetics or family history. So what else has changed? So obesity. We know that obesity is increasing in the United States and increasing in our younger cohorts. And when we look at obesity and colorectal cancer incidence and we look at the maps, we definitely see some overlap, though clearly this is not the total answer. This was looking at the Nurses Health Study, which is a large prospective study. They had 152 cases of colorectal cancer. And what they found was that a higher current body mass index or a higher BMI at the age of 18 and weight gain since early adulthood was associated with young onset colorectal cancer. So this was a large study, but still a small number, but it did seem like perhaps obesity did play a role. And when we looked back at our patients, when we looked at their BMI, if you combine the overweight and obese group together, they were more likely to be overweight and obese. But when we compare this to a national cohort without cancer, so that's the NHANES, our patients were actually less likely to be overweight and obese. And when we compared them to our average onset, those over 50, they were less likely to be overweight and obese. Diabetes, so we know that diabetes is increasing in the younger group. And in our patients, these numbers were small, but they did have an increase in diabetes. And so the question is there something, is there a trigger with diabetes? And this was an interesting study that was recently published. It was a Swedish study. And what they looked at, and they compared people with and without diabetes and with and without a family history. And so the green line is those with diabetes with a family history. And they were, in both men and women, were more, had higher incidence of colorectal cancer compared to no diabetes with a family history, and that's the purple line. The red line is diabetes without a family history, and as you could see, they had a higher incidence of colorectal cancer than those without diabetes without family history. So it seems that diabetes might be playing a role, and it's something that we're looking into, and it could be something that would trigger, maybe we should be screening people with diabetes earlier. Smoking is a known risk factor for colorectal cancer. When we looked at our patients were more likely to have never smoked and more likely to have never smoked compared to the national cohort without cancer, as well as the average onset. So these patients do not seem to be smokers. So is it something in the environment? And when we look at the maps and we compare those under 50 and over 50, there's definitely a difference. So perhaps there is something in the environment. And again, something that we are trying to investigate now. Lifestyle and diet. So we are moving less, we're eating a lot more fast food, we're drinking more sweetened beverages and less milk. So perhaps there's an answer in the diet or lifestyle. This also came out of the Nurses Health Study, which again was a large prospective study. And there were 118 cases of colorectal cancer. And they did find that sedentary TV viewing time was associated with an increased risk. And this was independent of being obese. But the risk increased if with a higher BMI, lower physical activity, and a smoking history. So your risk did increase with the known risk factors, but sedentary TV viewing in and of its own seemed to be a risk factor. Is the answer in the microbiome? So the microbiome is definitely a hot topic. And there are data to show that changes in the microbiome is associated with an increased risk of colorectal cancer in general. And something that has changed, the graph that I showed that the change was in the 1960 cohort. So something that has changed is that we've been giving out a lot of antibiotics. So perhaps there is a change in the microbiome that has triggered this increase in young onset colorectal cancer. But the bottom line to the $1 million question really is we don't know why this is happening, and more research is clearly needed to figure this out. So what about the patients themselves? We've studied average onset colorectal cancer a lot, but young onset is a though it's been published, it's really a new phenomenon for many people. And when you talk to a lot of these patients, they say that we are great at taking care of their cancer, but not necessarily their whole person. And so it's really important to think about issues that you might not think about in average onset, such as fertility. I'll talk about this. So this was a quality of life questionnaire, and this was through the Colorectal Cancer Alliance. And what you can see is that when they were asked, 85% experienced anxiety or depression during or after treatment, and 55% sought treatment. 80% had children under the age of 18 when diagnosed. 64% said a medical professional did not talk to them about fertility preservation during diagnosis or treatment. These patients are young, so the majority don't have a healthcare proxy or medical directive. As I showed you, the biggest increase is really in the 20 to 29 group. So this group, they're not thinking that they're going to have this life-altering diagnosis. So a lot of their orders are not in place. 64% had to take a leave of absence or quit a job or schooling because of their diagnosis, and 62% experienced financial difficulties. So I think that this chart is so powerful because what you could see is that the majority of these patients have psychosocial issues that may not be addressed. Moreover, it seems that there's a delay in diagnosis because I think that, a lot of people think you're young, you can't have colorectal cancer. And even if you have rectal bleeding, it has to be hemorrhoids. And it seems that it comes from both sides. So about 63% of patients waited before seeing a doctor. And women more than men waited over a year to see a doctor. A lot of times because either they don't want to talk about it or they think it's nothing because they're otherwise healthy. As you can see here, 67% saw at least 2 doctors before making the diagnosis, and some saw more than 4. They said that they were misdiagnosed by previous doctors, and half said that the one doctor said that they were misdiagnosed at first. So the majority of these patients are being misdiagnosed as hemorrhoids. Now, I just want to point out that the majority of young patients with rectal bleeding will not have cancer. And so that's an important thing to keep in mind, that most bleeding is not cancer, but this is something that has to be investigated. Unmet needs. So this is in all GI tract malignancies, but it seems that there are, as I said, a lot of unmet needs in this group. So these patients seem to have more symptoms. Like we said, they're young, they're in the workforce, they have young children. So a lot of times you see a deterioration in occupation, activities, coping with their children. A lot of people report unmet needs, mostly in nutritional counseling and psychosocial support. And those that require more than one treatment, so usually chemotherapy and radiation, which is how we usually treat our rectal cancer, which what I showed you is the majority are in that side of the colon. These have higher unmet needs. So our group seems to have an increased rate of unmet needs. Fertility concerns. So this again, this is for all cancers, not specific to colorectal cancer, but not surprisingly in women, cancer-related infertility is associated with more emotional distress and a decreased quality of life. And some women are willing to trade off survival to maintain fertility. In other words, they're willing, when we tell them the risks of some of our treatments, they're willing to either forego treatment or take a less effective treatment in order to preserve fertility. It's been shown that these fertility issues are discussed less with males, so it's not usually addressed. But when it is addressed, they really appreciate the support. And there's really a lack of evidence for our GI cancer patients. When we look at our treatments that we give our young onset patients, the effects on fertility are limited. There's an increased incidence of amenorrhea, so not getting a period in premenopausal women. The chemotherapies that we use can affect the ovaries, and the radiation that we use can affect the uterus. So these are definitely issues that should be addressed. So this was a study that was done in older patients, but what it showed is that our usual regimens for colorectal cancer cause an increased incidence of heart disease and congestive heart failure in those over 65. But the effects on the younger patients are unknown. So we're giving these treatments to people in their 20s, 30s, 40s, hoping to cure them and to have them live decades. And the question is, are we creating issues, cardiovascular issues, by using these treatments and in the future? And something that we don't know. And it looks like we're over treating these patients. So these patients are young, they're otherwise healthy, they have usually their hearts and their lungs are in good condition. And so we throw the kitchen sink at them because we want them to survive. They're young, they have young children. And so we usually give them so many treatments, but it seems that they're getting more intense treatment with unmatched survival gains. And a lot of these treatments have a lot of toxicities. And so I think it's important to take a step back and make sure that what we're treating makes sense. And how do we follow these patients? So we know that for those over 50, when they're diagnosed with colorectal cancer, we have specific guidelines that we do another colonoscopy a year after their surgery, and then 3 years after that. But for our younger patients, we don't know how often. And so a lot of us treated them like they had a genetic predisposition and doing colonoscopies every year. And some thought, it looks like the tumors are the same, so perhaps we can go longer. And the question is, we really don't know. And this was one study that was presented, and we're looking into this in our cohort now. But it seems that perhaps there may be some polyps or cancers discovered a little bit earlier than if you did it in 1 year and then 3 years after that, like in the average onset population. So we might start doing more frequent colonoscopies, but again, this is a question that we don't know the answer to yet. So the big question then comes, until then, should we start screening earlier? And here I listed the national guidelines that we have. And as you can see, the majority recommend 50, and I'm going to go over the data for this. So in 2016, the US Preventive Service Task Force, their guidelines, they said 50. And then in October of this year, they came out with draft guidelines recommending to start at 45. And these are draft guidelines that were given to the public for comment. They closed comment at the end of November, and we are all anxiously awaiting the final recommendations. But prior to that, they had said 50. The US Multi-Society Task Force had also said 50, with a recommendation to start at 45 for African Americans, and I'll go over the data for that. And in 2018, the American Cancer Society was really the first society to recommend starting at 45. And I'll go over the data as to why they recommended 45. And they made this a qualified recommendation and still recommended a strong recommendation to start at 50. So why was the age of 50 chosen? So here you can see that the incidence of colorectal cancer increases with age and really increases above the age of 50. And I think this is really interesting, and this was just published in 2020. I guess it's 2021 now. But when we used to say the median age of diagnosis was still in the 70s. But when we look now, because of the influence of young onset colorectal cancer, the median age of diagnosis has actually come down to the high 60s. So whereas in 2001 and 2002, the average diagnosis age was 72, it's now 66. So young onset colorectal cancer is really playing a role in this decrease. So when the guidelines were first made to start at 50, the question did come up, should we start at 40? And this was investigated. And when you look at the 40 to 49 group and you did colonoscopies on them, what you found was that the majority, you actually found nothing. There were no cancers, and there was a small rate of tubular adenomas. So those are the precancerous polyps, and it was small really compared to those over 50. Advanced polyps, so those more likely to turn into cancer, did have a 3.5% rate, but overall, because most of the time nothing was found and no cancers were found, the decision was made to keep the age at 50. So why did the Multi-Society Task Force in 2017 recommend to start earlier for African Americans? So you can see here that that in both men and women, African Americans still have a higher incidence of colorectal cancer. And though the incidence has decreased in Blacks, you can see that the decrease has not been as profound as it has been for whites or for all people. So the question is this due to biology? So when we look back at data, the majority of studies are retrospective, but we have two good prospective studies, but they show conflicting results. So in one large study, I don't know why it keeps on going forward. In one large study, they found that whites were more likely to have advanced polyps compared to Blacks. And in another study, they found that Blacks were more likely to have polyps than whites. So these are conflicting results. So it's unclear if this is due to biology, but I think many believe that this is really due to access to care. So this, we looked back at the National Colonoscopy Study, which was a large study that showed the efficacy of using colonoscopy to decrease the incidence of colorectal cancer. And what we found, I don't know why it keeps going, is that when you had equal adherence to high quality colonoscopy, there were no differences in polyps or advanced polyps between Blacks and whites. So it does not seem to be an issue of biology, but more access to care to high quality colonoscopy. And just a note on young onset colorectal cancer and race. So as I showed you, the incidence of colorectal cancer is higher in Blacks, but the biggest increase in young onset colorectal cancer that we've seen is really rectal cancer in whites. So what we find is that the incidence and survival is actually equal in whites and Blacks for young onset. So going back to the guidelines and the age to start. So in 2016, when the US Preventive Service Task Force was updating their guidelines, they wanted to see, does it make sense to start earlier? And what they did is some microsimulation data to see if it made sense to start at age 45. And what they found was that it was most efficient to start at age 45. But the additional life years gained if you start screening at 45 versus 50 was really small compared to the number of additional colonoscopies needed to get that goal. So in 2016, I don't know why it keeps on going forward. In 2016, they decided to keep the to keep the age at 50. And then in 2018, when the American Cancer Society was updating their guidelines, they took into account this young onset colorectal cancer. And they considered it a cohort effect, meaning that somebody who is 40 now is at increased risk of colorectal cancer. And we know that that risk increases with age. So by the time somebody who is 40 now is 60, their risk of colorectal cancer is higher than somebody who is 60 now. So when they put that into the microstimulation data, it did make sense to start at age 45. And so based on this microstimulation data, the American Cancer Society said, consider starting at 45. And they made it a qualified recommendation because it was based on microstimulation data and assumptions that doing these colonoscopies would decrease the risk. But the U.S. Preventive Service Task Force, who, as I showed you, came up with their draft guidelines at the end of 2020, also used this microstimulation data and saw, based on this increased risk of young onset colorectal cancer, their draft guidelines recommended to start at age 45 for everyone. And I'll tell you that since the 2018 guidelines came out from the American Cancer Society, many of us were recommending that if you're 45, get your colonoscopy, get your colorectal cancer screening. But because the U.S. Preventive Service Task Force still recommended 50, many insurances did not cover it. And that was the biggest blockage. But the good news is that services given an A or B grade by the Preventive Service Task Force must be covered by most private insurances. Now, again, this is based on final recommendations, and these are still in draft, but our hope is that the final recommendations will recommend starting at age 45, and then this will be covered by most insurances. But as I think I've shown you, we really need more research to understand the mechanism and biology of young onset colorectal cancer, the epidemiology, how we can prevent this, who we can screen, the best way to diagnose, what treatment we should use, the outcomes and survivorship, and then how do we follow these patients. So because of this, we opened our Center for Young Onset Colorectal Cancer in March of 2018. And like I said, the majority of patients said, you take great care of my cancer, but a lot of things have been missing. Nobody talked about fertility, nutrition. So we really focused on coordinated patient-centered care. So everyone sees the doctors that they would always be assigned to. So whether it be your gastroenterologist, oncologist, radiation oncologist, surgeon, but then everyone's also offered referrals to fertility, integrative medicine, nutrition, social work, sexual health, psychology, and psychiatry. And of course, we work closely with our other departments in the research arena. People felt alone because they're younger and a lot of their friends are, they were at the time, though now with COVID, most people are not going out, but people were spending time with their friends and their families. And a lot of these younger people felt alone. So, we send this letter out to everybody so that they know that they're not alone, and talk about all of the resources that we have so that they know that, we're taking care of more than just the cancer. We're taking care of the whole person. We have, through MSK Connections, we have an online support system where patients and their caregivers can go on and chat with other people. And as you can see, these were data from before the pandemic, but you can see that the majority of patients that we saw were above the age of 35. And in order to figure out why this is happening, we're obtaining questionnaires from everybody, and the questionnaires are looking at past medical history, family history, smoking and alcohol history, medication history, nutrition history, to try to figure out, is there something in the diet, in the lifestyle? Physical history, does it have to do with a sedentary lifestyle? And then looking at other things that we thought of that could have changed since the 1960s. So how were you fed when you were a baby? Breastfed, formula fed. Changes in the microbiome. Were you born by a C-section or vaginal birth? Talking about Wi-Fi, cell phones, laptops, the age of parents, and how often you sat on the toilet having a bowel movement, which is other things that has changed since the 1960s. And so our hope is that through the center and through collaborations, we can try to figure out why this is happening. So in summary, I hope I've shown you that colorectal cancer incidence rates in young adults continue to increase, and they're increasing at a steady rate. The majority of these cancers are left-sided cancers. These patients are presenting at later stages, many without a family history of colorectal cancer. The question is, again, is it genetic? Is it environmental? Is it behavioral? More research is clearly needed. So it seems that now in the general population, the recommendation is going to be to start screening at the age of 45. But this doesn't address the biggest increase in young onset colorectal cancer, which is in the youngest cohort, the 20 to 29. But there are currently insufficient data to recommend general screening in those under the age of 45. So I think that it is so important to increase awareness of young onset colorectal cancer so that both patients and providers are aware that this exists and that rectal bleeding in young patients does not mean hemorrhoids in everybody. Again, I wanted to iterate that rectal bleeding is usually not cancer, but there really has to be a prompt evaluation of symptoms. It happens once, it's unlikely, but if recurrent symptoms or any questions, really to have a prompt evaluation of symptoms, because colorectal cancer is a potentially curable cancer if found at early stages. And so if we're able to have a prompt evaluation of symptoms, and we can try to help decrease the incidence and mortality from this potentially curable disease. Thank you. Any questions?
Thank you very much, Dr. Mendelsohn, for an outstanding presentation. We have lots of questions in the chat box, and we certainly want to encourage you to use the chat box. If you have a question pertaining to Dr. Mendelsohn's presentation. The first question, and I'll go ahead and read them for you, Dr. Mendelsohn.
Okay.
The first question, why is there higher incidence in males versus females?
So in average onset, there is an increased incidence in males versus females, and for average onset, and we think it's probably hormonal in nature because the average age at diagnosis for females is higher than males. So we think it's probably hormonal. In young onset, though, it seems to be equal. So it doesn't seem to be that men have a higher incidence compared to women in the younger cohort.
Thank you. There's a comment. This was from our president, Dr. Carlisle, and I'm not sure if I think he had to leave. He said, when I was a resident, I had a 15-year-old patient from Korea with metastatic colon cancer.
Yeah, it's definitely a worldwide phenomenon, and we are seeing it in the youngest group. You know, it's very rare in that younger group, and in that youngest group, they do have a higher rate of genetic syndromes, but we are seeing it in these young patients that have no family history.
Our next comment from Dr. Bhatgama, our VP of Research, we also observed from our study with the King-Drew patients, young early onset CRC in the late 90s.
Yeah, you know, it was published, and it's something that we have been interested in for a very long time. And it's finally getting press, which, unfortunately it took an untimely death to do so, but we're hopeful that now that it is out there that people will address it.
I will, Dr. Mendelsohn, thank you again. I will wait for the time to read the other questions on the chat and then maybe share some observations and work that's ongoing at Charles Drew in our oncology program.
Yeah, that would be
everything you described. You mentioned it's just exactly, so many areas are consistent in terms of what we've been seeing. And you guys have done a fantastic job. I appreciate that.
Thank you.
Let's see, the next
Go ahead.
question. The next question, I am trying to figure out what is happening with those in the 50 to 57 range that have been getting colorectal cancer screening, but cancer has not been detected until late stage. My husband, ex-husband, and other male friends were getting screenings, but it was not detected until it was too late. My husband is the only one in the group to survive.
Yeah, we think, as the data that I showed where the 50 to 54 group is increasing. And so, like I said, that the time that we think it takes from a polyp to turn into cancer is about 10 years, which is why the interval is usually 10 years once you have a clean colonoscopy. But it seems that perhaps with young onset colorectal cancer and with these numbers increasing in that under 55 range, that something might be happening earlier. And why that is, we don't know. But I think decreasing the age of starting screening to 45 will help at least address that age group.
Next question, are those with a genetic predisposition more prone to higher mortality rates?
So that's a good question. There are multiple genetic disorders, and the most common cause of hereditary colorectal cancer, as we said, is Lynch syndrome. And interestingly, when we look at Lynch syndrome patients, from when you compare stage for Lynch syndrome versus sporadic, the Lynch syndrome patients actually do better. And what we think is that it's because of certain inflammatory cells in the tumors that are actually protective. So though they have higher mortality rates compared to the general population for cancers, but when you compare patients with colorectal cancer who have Lynch and who don't have Lynch, the Lynch patients actually do better.
Few comments from Dr. Dominguez. Excellent presentation and with great visuals. And I had a recent friend die from CRC at 70. He was detected too late, but his brother was diagnosed early and survived years before. Maybe a lesson.
Yeah, so I didn't, just in the interest of time and the topic, I didn't go into all the different screening guidelines, but if you do have a family history of colorectal cancer, you're supposed to start at age 40 or 10 years earlier than the youngest person in your family was diagnosed. So if the youngest person in your family was 60, you start at 40. If it was 45, you start at 35. So if his brother, was diagnosed early, then it might have been that that he should have been screened early. I don't know about the specific circumstances, but I'm sorry to hear about your friend.
Next question, is there a relationship between colorectal cancer and prostate cancer?
Not that we know of. There are some genetic syndromes that may overlap, and some do suggest that Lynch syndrome may be associated, but we don't really think so. They both are common cancers, but there doesn't seem to be a relationship.
What about HPV infection? Is there an association with HPV infection and early onset colorectal cancer?
So no, that's a good question. So HPV is usually associated with a squamous cell cancer, and the majority of young onset colorectal cancers are adenocarcinomas. So it's a different type of cancer, but it's something that we're looking into because it's there is an increase in HPV infection, and there is a great vaccine. So you would hope that the vaccine would actually decrease the risk of young onset colorectal cancer, but it doesn't seem to be associated.
Question from Dr. Richard Allen Williams. Screening for CRC appears to involve a healthcare disparity as concerns Black males. Why is the USPSTF not in favor of early screening, despite some evidence that early screening can result in early detection? Is the screening age as low as 45 out of the question?
So yeah, so the U.S. Preventive Risk Task Force is recommending to start at 45 for everybody. So the Multi-Society Task Force had decreased it to 45 for African Americans for exactly that reason. Even though, as you point out, it seems that it's a healthcare disparity as opposed to biology. So the U.S. Preventive Service Task Force is in favor of early screening for everybody now.
With the increase of microplastics in our ecosystem and diets, are there any studies exploring this, perhaps in the microbiome?
So we are definitely looking in the microbiome. I actually have a grant to look at that. Unfortunately, with COVID, we haven't been able to collect stool from everybody because we're doing many things remotely. So our research has halted a little bit, but we're hoping to pick it up again. But we're definitely looking in the microbiome, and diet is notoriously a very difficult thing to study, and we're finding it very difficult to study in young patients because I can barely remember what I ate last week, let alone when I was a child. And there's also a lot of guilt that goes along with it because the younger patients that get it, the parents feel like it might have been their fault for how they fed their children. So there's a lot that goes into nutrition studies, and so they're notoriously difficult to do. We're doing the best that we can, but I'm not sure we're going to be able to find an answer, but definitely exposures. And we're working on this in New York City in a collaborative effort, nationally and both internationally, to try to see if there is something that could have triggered this.
And along the same lines regarding diet, the final question in the chat box, is there a difference in incidence among vegetarians versus non-vegetarians?
So that's a good question. So there are data to show that that red meat consumption does increase your risk of young onset colorectal cancer in general. There aren't great studies, again, looking at younger patients, and again, it's somewhat difficult to do, but definitely an association with red meat and processed meats in general. But this is definitely something that we're looking into. Anecdotally, so many of our patients don't fit the typical picture of the risk factors with obesity, alcohol, tobacco. So many of our young patients are healthy, marathon runners, vegetarians, and you would never, they don't have any of these known risk factors. So I think, something will come out. We normally think that, eating a plant-based diet is protective, which plant-based diet doesn't mean vegetarian, but we normally think that should be protective, and it's unclear, but something that we are looking into.
Thank you, Dr. Mendelsohn. And sorry, I see Gloria Goodwin with her hand raised. Gloria, do you have a question that you'd like to ask?
No, I'm sorry.
No worries, no worries.
I'm sorry.
No worries. Thank you again, Dr. Mendelsohn, for such an insightful presentation. We truly appreciate you taking time out of your schedule to join us and to be our first featured guest for our annual lecture honoring Dr. Erik Fleming. We thank you.
Thank you. It was really an honor and privilege.
Thank you, Dr. Mendelsohn.
And Dr. Badgam, I know you wanted to share.
Yeah, well, I think, Dr. Mendelsohn, I will get in touch with you, and just want to give you a heads up. Everything that you presented just brings more excitement to what we are doing in partnership with UCLA. I first started with a grant funded with Mayo Clinic, actually asking the very same questions, because we were seeing very young, in the late 30s, early 40s, African Americans and Latinos with early onset colorectal cancer. And we asked the same questions, was it ethnicity, race, was it the site of where the tumors were detected, proximal, ascending, descending. And our data showed actually a large number of kind of the sites which were located in our study was the descending column and the rectal area, hence the poor outcomes as well. We ask questions such as mismatch repair proteins, microsatellite instability. You know all of that. We've been looking at that extensively. We have about a cohort, about 700 participants over the years that we've been following and have blood collection, serum plasma, you name it, tissue. So I'd love to collaborate with you. One area that you touched on, and maybe perhaps you were a little gentle with the United States Prevention Task Force. I think this has been a major problem in our country for many years about the uncertainty and being indecisive in terms of the age of screening. And I remember I had a young Latino GI fellows in the early 2000s, and we were seeing at early stage, and we went and presented at your meetings at the annual gastroenterological studies. And by the way, he got a presidential award. But the point was that our recommendation was we got to start screening at a younger age, particularly of family members who could be at risk. So I think that's very, very important. And I think I rather stick to the American Cancer Society guidelines or the AACR and so forth. But hopefully the task force is catching up with what's going on in reality. There's one area which I think I just want to show same data that you have. Well, vitamin D plays a big role. Deficiency in vitamin D is a problem. Obesity, comorbidities is a problem. And all of those are confounding factors that we are seeing in terms of increased incidence of colorectal cancer. One area that we've been studying lately is the role of inflammatory chemokines and cytokines. And our studies begin to show now that the role of STATs, for example, STAT1, STAT3, and FKB B and others are extremely critical. And these are really exciting biomarkers to follow both the early incidence as well as progression of the disease. And if in particular, if treatment, this is where the problem lies, as you know, if the treatment is making any difference, and if those chemokines and cytokines don't change significantly, the metastatic tumors that we see and poor outcomes are not going to get better. So I think the thought of coming up with better targeting with that area would be something to think about. So I'm really, and this microbiome thing that you are looking at, we have a study with UCLA right now looking at very similar questions. And I think that's going to reveal a lot of very exciting outcomes as well. So I really enjoyed it. I promise you we'll be in touch with you and hopefully we can set up some collaborations.
Yes, absolutely. I look forward.
Thank you.
Thank you.
Hello.
Hello. I would like to now introduce Dr. Roberto Vargas, who will provide closing remarks for today.
Great. And Kiyosha, I just want to check because I think Dr. Williams had a comment, but I'm fine.
I'm sorry. I'm sorry.
If I could make just a very quick comment to follow up on what Dr. Vadgama just mentioned, and the question that I asked in the chat about the U.S. Preventive Services Task Force. It appears that there's a sort of a disconnect, if you will, between recommendations that are made by that task force and the American Cancer Society regarding age of screening. And that seems to have been going on for some time. I'd just like Dr. Mendelsohn to comment briefly on that because, as was mentioned, it sounds like you were being a little gentle in regards to the task force and their requirements. And finally, that their requirements are taken very seriously with their recommendations. If it's not, if my impression is not incorrect, I think that in order for screening to be done by a practitioner to get insurance coverage, it has to be approved by the task force. So in other words, if you were going to screen somebody under the age of 50 or 45, if the task force doesn't approve of it, insurance doesn't cover it. And that's extremely important from the standpoint of picking up or detecting people who may have this disease. And
Yes.
actually, my question that I asked was whether it's unconscionable to think about lowering that age to 40 rather than 45. I know 45 is approved now. But just if you can comment on perhaps the controversy between those two major agencies.
Right. So, yeah, so that's why I presented the data that they used to come up with their recommendations. So, the data, the data that the American Cancer Society went off of for 2018 was, again, microsimulation data. So it wasn't hard population data. And American Cancer Society still did not make a strong recommendation to start at 50. They still made it a qualified recommendation. And so it's hard for insurances to cover if they're making it a qualified recommendation, not a strong recommendation, but they do go by the Preventive Service Task Force. And so based on those changes in 2018, so 2 years ago, it was about 2 years ago, they then, came up with their most recent draft guidelines. So that was the difference. And like I said, the Preventive Service Task Force did look into it back in 2016, but the number of colonoscopies needed to really make the difference, it didn't make sense. And, I think it's important to remember that in the United States now, we don't have great adherence to colorectal cancer screening in general. So for 50 and over, our goal was to get 80% screened by 2018, and we didn't make that. So, you have to look at resources and try to figure out, it's still under, you're still more likely to get colorectal cancer as you get older. So, decreasing the age to 40, of course, I wish we could screen everybody. That would make, us feel a lot better if we were able, but we just don't have the resources to screen everybody. So we have to figure out, who should get screened and in what ways. And, I didn't have time to really go into all the ways to screen for colorectal cancer, but there are stool-based tests and there's colonoscopy. And so perhaps in the younger groups, we can use stool-based tests as a triage to see who should get colonoscopies. And a lot of the stool-based tests perform better in younger people. So perhaps that's where we should be focusing that. And that's something that we're looking into. And obviously prevention is key. And so not only looking to see what age we can, what age group should be screened, but, perhaps we can find a high risk group, like I spoke about diabetes. So perhaps younger people with diabetes, we can start screening them. In an ideal world, everyone would get screening, and but unfortunately, we don't have the resources to do that. So we have to figure out why this is happening, or a high risk group. Decreasing to 40 again. I think that would be great, but I just don't know whether we have the resources or the data to show that would make a difference. It might be that you'd have to do a ton of colonoscopies to really see a difference.
Thank you. So I'll go ahead and turn it on over to Dr. Roberto Vargas, who will provide closing remarks for the day. Dr. Vargas is Assistant Dean for Health Policy and Interprofessional Education and Associate Professor with the College of Medicine. Dr. Vargas?
So thank you, Dr. Partlow. And I want to thank the Fleming family. I want to thank all of you for really joining us for this first lecture today. It started off with a description of Erik and his life that I believe is equally shared by anybody who knew him. To hear about his views and the way at 10 years old, that spirit of giving that I got a chance to personally see for many years, from when he was a student to actually becoming faculty. It's something that can be really saddening to know he's not with us, but encouraging to know that spirit existed in someone that we have had the pleasure and privilege to experience, even though it has been brief in terms of his life. When I was thinking about these comments, this is a tough one because when I came on to lead the policy group, Erik reached out to join our policy pillar. I went back and I looked at my notes that I had taken. Erik and I had regular meetings, and I was looking forward to being his mentor. and knowing the work that he did, and to hear the article that was referenced by Mohsen Bazargan, and the fact that what people were calling translational research and had many different interpretations was something that we took to heart, that it really did talk about the fact that there are these things that we know as scientists and physicians and as public health professionals that are not getting to everyone who needs them. If we put this in the context of today's talk, Dr. Mendelsohn has shown us that when African Americans and white patients receive the same type of high quality colorectal cancer screening through colonoscopy, that the outcomes are very similar. And so that, that what we can do to eliminate these disparities, to really live in a world without health disparities, are things that don't require a new discovery from the basic science world. It doesn't require a new clinical trial. It requires us looking at things that we have right in front of us and making sure that they are distributed equitably. And so from the 10-year-old who said, let's give our resources to people who don't need them, to the work that he started off saying, we can translate our findings into these improved outcomes, to what I talked about with Erik when we had our meetings looking at our notes about what he was going into in terms of this world of diabetes-related disparities, knowing that we could treat diabetes and cure diabetes or reverse the negative impact of the diabetes outcomes through access to care, and how he wanted to merge what he knew from information sciences and population health that he had studied to what is our mission at Drew, which is to reach out to those who are in need or who have not had the benefit of access and reverse that, to stay explicitly in our mission that social justice and health equity is who we are as a university. And as a university, we're a family, is consistent with the lessons that I've learned from being in his presence during his time. And so his life taught me a lot. His death was hard for me. It was hard for many of us who knew him. It's incredible to think it was a year ago this time which he passed away, and that his death was probably the last time that we were all in each other's presence. For his funeral, when we all got together, little did any of us know what was waiting ahead of us in this coming year. And so to be with you all at that time, and for all of us to be together and not to know what we're going into, is another thing that I take away from his life and unfortunately his death, which was that we don't know what's coming, but that the lessons I learned from him in terms of his perseverance in the face of adversity are things that were very closely aligned to the weeks that we would face as this pandemic put us all on our heels in fighting against it and exacerbated the disparities we saw, highlighted the disparities that we knew, and provided an example for us real time of what needs to be done to ensure that the things that we have control over and the knowledge that we have gets equally distributed. And to have to face this pandemic in the context of racial injustice and the highlighting of what's happened in terms of racial injustice, to face the pandemic in the face of an inadequate response from our political leadership that has exacerbated death and disparity amongst our people, is enough to make you want to just quit. It's been a hard year for so many of us, but to have that come in such close proximity to us losing Erik, and when we had the chance to collectively grieve and reflect upon his life, I believe it prepared us for what we have had to face in this past year. I have been proud to be a part of this university and this family, because our collective response, from social support to direct outreach, putting our needs of our community out front, and so many of you who've done that, while also balancing the need to create objective knowledge and information through our research and our activities, but doing that only in the context of action, has reminded me so much of why I can say that we can be proud to be a family and to let everyone know that we are a very unique and special place amongst the Academy. And it's a pleasure and an honor and a privilege to be among you. And I'm glad that we have brought this lecture into our standard, and that we can show people that you can create knowledge, that you can be objective, that you can have high academic standards, but you can do that in the context of a mission, which includes social justice, in the context of a mission that includes health equity, and that you can be proud to do that in the spirit in which this man lived his life. And I'm so thankful to have this lecture. I'm so thankful that this lecture will be a part of our standard moving forward. It is consistent with everything that I've known him to be about, and that I'm hoping will serve as a legacy to move forward and to support his spirit. And so with that being said, I'm going to leave the final remarks to his family. And I believe Star Fleming is going to give us our final comments. Thank you.
Excellent. Excellent.
Thank you, Dr. Vargas. Thank you all for attending. I know it's an interesting way to spend your lunch break, but we really do appreciate it. You know, Erik unfortunately was one of those statistics with his illness, but as he said, being a great achiever is about refusing to fail and transcending above stereotypes that are prevalent. So I hope that this talk inspires all of us to be the achievers that he was and to work to eliminate healthcare disparities, which is something he was so passionate about. Dr. Mendelsohn, thank you so much for being here. I know I stalked you and hunted you down, but I'm so glad that you were able to share in this. You know, he would be so proud of your talk and the research that you're doing. And, you know, had he survived, I'm sure he'd be right there next to you, fighting that good fight. I don't have any research skills. I can research where the best sales are, but other than that, so I will leave it to you and his colleagues, you know, to help continue fighting this fight. And, you know, we lost Erik and other great men, Chadwick Boseman, to this challenging disease. And, you know, I miss him every second of every day, but we should rise to the occasion and try to make the world better place in honor of Erik and make it a much better place in the world for his son. So all of us are going to continue to fight for Erik and EJ, and continue to do great work. He spoke so highly of all of you. He loved his job completely. He was a Drew lifer, I know that for sure. So thank you so much for being, you know, a family to him outside of my home and outside of our home. So I really appreciate it. Thank you.
Thank you very much, Star. We have a short video to share with you.
I love you, Daddy. I'm so proud of you. I can't wait to grow up and be just like you.
Inspiring the next generation, indeed.
Wow.
So on behalf of everyone at CDU, on behalf of the urban...
Can I get a quick replay of EJ?
Sure, absolutely.
We have some of my Viacom colleagues on the phone, so this is his big audition, guys.
Absolutely.
I love you, Daddy. I'm so proud of you. I can't wait to grow up and be just like you.
Thank you.
Awesome. Thank you. Thank you, EJ.
I say thank you. Say welcome.
You're welcome.
You're welcome. I would just like to say thank you to everyone. This was such a great way to kind of memorialize some of the things that I know that Erik believed in and loved. And Dr. Mendelsohn, thank you so much for being the inaugural speaker. I truly feel blessed with that. But to UHI and to all of those, to everyone, thank you for being a part of our family and showing your love and support as you've done for so many years. Thank you.
Thank you. And thank you so much to the Fleming family. This was a collaborative effort, and this was, it was amazing working with you all. Star, finding and suggesting Dr. Mendelsohn. So, we really appreciate you as well. And we are here to support you always. Thank you, everyone. Thank you to the UHI team as well for doing such a great job. And we just thank you guys for spending your Wednesday afternoon with us. We are definitely going to begin planning for next year. And we hope you all have a great rest of your week. Thank you to all.
Thank you. Bye-bye.
Thank you so much.